two questions to compare between them. Sorry. First of those two questions is about a 65-year-old man who underwent three vessel coronary artery bypass grafting, CABG, 5 weeks ago, comes to the office because he has a draining lesion near the sternotomy excision. The CABG procedure included harvest of the patient's left internal mammary artery. Temperature is 38.7 degrees centigrade. Physical examination shows a 3 mm papule at the manubrium of the healed sternotomy incision. CT scan of the chest shows a sinus tract leading to the internal sternal plate. In addition to removal of sternal wires and debridement of the wound, which of the following is the most appropriate management? First of all, continuous irrigation. B is negative pressure wound therapy. So A is continuous irrigation. B, negative pressure wound therapy. C, omental flap. D, pectoralis major muscle flap. E, rectus abdominis muscle flap. The correct answer is pectoralis major muscle flaps, number D. So, pectoralis major muscle flaps, the most effective treatment in the sternal wound infection described in the initial debridement of healthy bleeding tissues and bone removal of all foreign bodies and immediate closure with bilateral pectoralis major muscle flaps. Past sternotomy wounds are classified according to the duration of time that have elapsed between the sternotomy and the clinical onset of the infection. Type 1 infection occurs within the first week after sternotomy and have no bony involvement. Type 2 infections occur during the second to fourth weeks after sternotomy. Bony involvement is frequent, but costochondritis is rare. Type 3 infection occurs months to years after sternotomy and typically involves chronic draining sinus tracts. Osteomyelitis, costochondritis, and retained foreign bodies are all common. The patient described had a type 3 infection with a deep sinus tract as confirmed by CT scan. Although delayed closure have previously been considered the treatment of choice for type 3 sternotomy wounds, more recent data suggests that a single stage approach with bilateral pectoralis major muscle flaps results in quicker recovery, improved cosmetics, and decreased morbidity and mortality compared with staged approaches. Given the chronicity of the wound, all foreign bodies, including retained suture materials and wires, should be removed. Pectoralis major turnover flaps provide additional bulk and might therefore be considered preferable. However, the left internal mammary artery has been harvested in this patient, compromising the blood supply to the left pectoralis major turnover flap. The other question is about 68-year-old woman. The first one here was a 65-year-old man. Here, 68-year-old woman who underwent a 3-vessel coronary artery bypass grafting CABG 7 weeks ago. Presence, the first one, it was 5 weeks ago. Here, 7 weeks ago. I want you to remember about the stages. Which one? Uh, 7 weeks ago, presence to the office with a 6 mm indurated lesions at the manubrium of the heel sternotomy incision. She also has no two draining incisions, one and 1.5 centimeter lateral to the sternotomy incision. The patient says that these two lesions began draining approximately 3 weeks ago. The CABG included harvest of the left internal mammary artery. CT scan of the chest demonstrates a sinus tract leading to a 4 to 6 centimeter fluid collection in the substernal region. After removal of the sternal wires and debridement of necrotic bone and cartilage, which of the following is the most appropriate reconstruction? Objects: A. Bilateral pectoralis major advancement flap. The other one, B. Bilateral pectoralis major turnover flaps. C. Left rectus abdominis muscle flap. D. Omental flaps. E. Right latissimus dorsi flap. The correct response is A, which is bilateral pectoralis major advancement flaps. The most common and potentially devastating complication of median sternotomy is infection resulting in wound breakdown. Other complications seen less frequently are mechanical breakdown of the wound secondary to inadequate wiring technique, poor bone mechanical breakdown of the wound secondary to inadequate wiring technique, so poor bone quality, and chronic obstructive pulmonary disease COPD associated with uncontrolled severe coughing. Before the use of muscle flaps, closure of the sternal defects mortality was in the percent the 50% range. Subsequent to the development of muscle flap technique, this has been dramatically reduced to 15 to 30% range, and even lower in many institutions, less than 5%. The treatment options for sternal wound closure, including unilateral pectoralis major muscle turnover flaps, the unilateral pectoralis major muscle rotation advancement flaps, the rectus abdominis muscle flaps, bilateral mucocutaneous pectoralis major muscle flaps, latissimus dorsi muscle flaps, and the omental flaps. Pectoralis major advancement flaps based on the thoracoacromial vessels are the first line option for coverage of sternal wounds. The left internal mammary artery has been harvested in this case, compromising the vascularity to the left pectoralis major turnover flaps and the left rectus abdominis flaps. The latissimus dorsi flap is a second line choice. The presence of other reconstructive options. Omental flap is used when a large mediastinal dead space needs to be filled. So according to those questions, they are about um, let us say osteomyelitis of the sternal after operation, and what is the most important way to cover. In the first question, pectoralis major muscle flaps. In the other one, bilateral pectoralis major advancement flap, because in the other question there is another choice, either bilateral pectoralis major advancement flap or bilateral pectoralis major turnover flap, and we will use bilateral pectoralis major advancement flaps. So just please make like, share this video with your friends, put a comment about your questions, and subscribe to my YouTube channel.